To the stage, Axios health policy reporter Maya Goldman.
Hello, good morning, everybody. Thank you so much for being here. I'm Maya Goldman, healthcare reporter at Axios. This is the fourth event in our pain management series. We are so excited to close it out with you all here in New York City. We're kicking off today's conversation with a national leader who's rethinking pain management in the emergency room, a pioneer in non-opioid approaches to acute pain care. Please join me in welcoming Dr. Sergey Motov. Thank you so much for being here today. It's great to have you.
It's my pleasure to be here today.
I want to start with a little scenario. Tell us, so when a patient comes into the Maimonides ER with acute pain, what is the protocol you use to treat them? Walk us through what that looks like.
Okay, so I take a pride, and I'll speak on behalf of my amazing democratic group, that we're very focused on what I called individualized, patient-specific, pain syndrome-targeted approach to their painful complaint by combining a variety of treatment modalities, primarily focusing on combining non-pharmacologic, non-opioid, and opioid therapies. I'm happy you brought the word protocol. What we've done as a democratic group, we've transitioned from actual stringent protocols, depending on the patient presenting complaint, chest pain, abdominal pain, to an order set in our electronic medical records that lists available analgesics that can be customized, once again, to patients' individual painful complaint.
Yeah. Wow. So what are some of those different things that you might give to a patient?
Well, we can start with, depending on the presentation, let's say if we're talking about the traumatic pain, we can start with cryotherapy, simple ice pack, splinting, immobilization, and we can transition to non-steroidal anti-inflammatory medication if they have no contraindication for it, which could be combined with either regional anesthesia, ultrasound-guided, and targeted sort of optimized opioid therapy, once again, based on their presentation, comorbidities, risks, and drug-drug interactions.
There's this whole world of pain management that we don't always think about when we're thinking about that. We're obviously still in the throes of an opioid crisis. What is the role of the emergency room in preventing that from getting worse or possibly even reversing it?
When it comes to opioid crisis and role of emergency physician, I usually like to say that we, practicing clinicians, are very uniquely positioned to take care of patients in pain in safe and effective manner, once again by combining a variety of non-pharmacologic, pharmacologic treatment modalities, opioid and non-opioid, and focus on sort of preventing development of opioid use disorder. And if I may, I'd like to bring to your attention, I call this 3Ps concept. 1P stands for prevention of opioid use disorder, but prevention focuses primarily on preventing under-treatment of pain by optimizing therapies we have and by reducing potential of patients primarily receiving opioid therapy to misuse, abuse, and divert them, and of course reduce the risk of development opioid use disorder. That's number one. Second P is protection. And our department will be at forefront of utilizing harm reduction strategies, such as identifying patients who are at risk of opioid misuse, abuse, and diversion, and having conversation with them, providing take-home naloxone, talk to them about safe injection practices, needle and syringes exchanges, right? Explain the risks of unsafe opioid consumption practices, referral patients to behavioral therapies, and the list goes on and on and on. And the last P is prescribing or prescription. We are identifying patients who are suffering from an opioid use disorder, and in our department and in many departments in the country, we are very equipped with knowledge and expertise to initiate what's called induce an opioid agonist therapy, which is life-saving, such as buprenorphine. So that's the 3P concept: prevent, protect, and prescribe.
I love an alliteration. So sounds like you're saying opioids do still have some kind of role to play in acute pain management. How do you decide when that's appropriate and when to avoid it?
Excellent question. I am a firm believer that opioids do belong in armamentarium, specifically when it comes to acute pain, of practicing ED clinicians. But their use need to be refined. And I like to use word optimization. You know, everybody in this room and everybody who's watching us right now live are familiar with the concept of policies and regulation geared toward opioid minimization, opioid reduction, and even elimination. And I personally believe it's not the right message. The right message is opioid optimization based on individual patients' presentations. And if we do this, we'll be very, very successful. The whole aspect of pain should be focused on patient needs, patient-specific approach, almost to the point, what would patient want? And the concept of engaging patients in shared decision-making about natural trajectory of their painful condition, about what works, what doesn't, and have a conversation about them with opioids would be very beneficial.
Yeah. When patients come into your ER, do you find that they're often concerned about taking opioids? Is that something that people talk to you about?
Yes, at present, we may not be giving enough credit to patients coming to the emergency department. Yes, there are concern, there are fear, palpable fear, and sort of rightly for it, that I don't want to have an opioid because I don't want to get addicted. But we need to be smart. Again, we need to balance the potential to be addicted to an opioid to an effective and relatively safe patient pain management practices, right? Yeah. And once again, opioids belong to the second one. They're part of this safe and judicious pain management practices.
Yeah. So switching gears slightly, we're here today to talk about the future of pain management. There are lots of exciting things happening. One of those things that there's a growing body of evidence on is ketamine for acute pain. What are you seeing on that front?
So ketamine, as a physician scientist, as a physician researcher, I've spent almost 15 years of my researcher life pursuing concept of ketamine analgesia in the emergency department and beyond. And I can, obviously I'm biased because of it, but I can firmly attest that ketamine given in so-called sub-dissociative dosing ranges, also known as analgesic dosing ranges, or low, either as an adjunct to opioid or non-opioid therapy or as a single entity, has been found to be very effective in managing a variety of acute painful conditions in the emergency department, primarily for the short term.
So what does this look like? Is it an IV? Tell us a little bit more.
Absolutely. So the main route that we use ketamine for pain is intravenous, and it's usually used, again, I mentioned, in low or so-called analgesic dosing ranges, usually as a short infusion over 15 to 30 minutes. In the absence of intravenous accesses, either because you can obtain this in an appropriate amount of time or simply unavailable, you can use intranasal route. And recently, personally myself, we've been utilizing inhalation route via nebulization.
Interesting. And what does that do to the patient? How is that working?
So ketamine has been found to be very potent analgesic. And balancing ketamine analgesia with development of so-called psychoperceptual adverse effect, mainly related to feeling of unreality. It feels like it's like Alice in Wonderland, not quite dissociated yet, but you get in there. Has been very big passion of mine, but I can attest it's been found to be very effective. Numerous randomized clinical trials, systematic reviews, meta-network analysis pointing towards the fact that it's effective in pre-hospital settings, adult patients, pediatric patients, and even geriatric patients.
Wow. And is this something that is still in clinical trials, or can you prescribe this right now? What's that looking like?
So as of right now, there is no FDA-approved formulary of ketamine that is available for pain on an outpatient basis. Despite the proliferation of telemedicine and outpatient ketamine clinic, that's how it stands. My expertise primarily focusing on utilizing ketamine in inpatient settings, such as in the ED. So to answer to your question, simply no, there is no actual ketamine formulation in the United States that we can prescribe and send patients home to.
Yeah. So with ketamine and also with other opioid alternatives, what do you need to see? What kinds of changes do we need to see from a systemic point of view to make these more accessible to people, in your opinion?
I like that. So I'm going to bring three major emperors of successful pain management: science, policy, and practice. And if we combine these two, science, when it comes to ketamine research, despite the fact I mentioned to all of you that there's a great body of evidence, but we need to focus on the science that is more inclusive, more equitable, and definitely focusing on vulnerable groups of patients, pediatric, geriatric, patients with a low socioeconomic status and such. And we need to, second part when it comes to research, we need to be maybe better with implementing or translating research data into clinical practice, because areas such as physician skepticism or hospital inertia or concern for either severe adverse effect or reimbursement to that extent may impede our ability to implement ketamine therapies in the acute care settings.
Yeah. Tell us more about the reimbursement challenges in pain management in general.
So the general is their concept of volume-based care, which everybody's sort of moving forward, doing procedures. Some may not be necessarily indicated, or prescribing medication only because they've been reimbursed. And most of you, if not, and definitely Maya, you know, because I follow your work, it's been fascinating, that non-opioid analgesia, let's say in the surgical space traditionally, have not been covered as separate entity. Well, No Pain Act actually making a difference. And I'm very happy and optimistic the fact that non-opioid analgesia will get its proper recognition and definitely proper reimbursement. But going back to what I mentioned, to moving from volume-based care to value-based care, but we need to be very careful how we interpret value. It has to be patient-centered. And the metrics are functional improvement rather than the number of pills we give. And no matter what you give, either opioid or non-opioid, functional improvement, right? Interference of pain with activity of daily living, pain recidivism, which is translated into return visits to the emergency department, and overall safer pain prescribing practice with respect to adverse effect. These are the metrics. But before we get there, I know it's there, but it's not quite there. So nationwide advocacy for value-based care, right? Real world cost effectiveness data, and maybe proper quality metrics. What I said, it's my opinion, but they need to be sort of put together in a great perspective as a nation, and then we'll be able to succeed.
Yeah, and you mentioned No Pain. That's a bill in Congress that would change reimbursement for non-opioids, non-opioid pain management.
Non-opioid pain management.
We only have a minute left, so this will be our last question. But you were telling me backstage that one of the reasons you got into pain management as a medical practice was because of the way that you saw your attending physicians when you were a resident treat pain with opioids kind of willy-nilly. How has that changed in your time since you've become an attending yourself? What's the perception change like in the ER?
The perception is palpable. I think emergency clinicians made a huge difference and a huge stride in advancing their knowledge, specifically focused on neurobiology of pain, broadened their use of non-opioid analgesia. We mentioned several: nonsteroidal anti-inflammatory medication, regional anesthesia, ketamine, non-pharmacological treatment modalities, virtual reality, physical therapy, and focus on, again, refined and more judicious use of opioids. But I want to reiterate, focusing on optimizing opioid therapy, not minimizing or eliminating.
Well, thank you so much, Sergey. It's great to talk to you. Stay with us. Next up is Axios' Nick Johnston.
Thank you.
Introducing our View from the Top moderator and Axios publisher, Nicholas Johnston.
Everyone, I'm Nicholas Johnston, the publisher of Axios. Thank you so much for braving, I guess, a light mist this morning for this conversation. We're so grateful that you're here. We're also hugely grateful to all the partners that we work with at Axios. Nothing would be possible without the support of the partners, the investments we make in local journalism around the country, and the convening of conversations like this. So a huge thanks to Vertex Pharmaceuticals for making this conversation possible, as well as conversations we've been having for the last couple of months around the country. And so I'm very excited to welcome back to the Axios stage from Vertex, their Senior Vice President and Disease Area Executive, Paul Neglescu. Paul, welcome back. How are you? Great to see you again.
Hi, everybody.
Let's start big picture, like we usually do. Give us a sense broadly about why convening this conversation and why Vertex is here.
Right. Well, thank you for hosting us. Thank you for the invitation to be here. Pain is the most common reason that people go to see the doctor. So the reason we're here today is that pain is just such an important medical condition. It affects almost every one of us at some point in our life. And we simply need more options to treat it. There's a lot of unmet need in that space. And so we're here today to try to talk about that and to try to help bring different perspectives to the floor to hear about the unmet need.
You've been doing research, I know that we've talked before, and I think there's some top lines we should probably share here for this new audience. You've been digging into the incidences of this and how people approach it. What have you learned? What are the top lines?
So one of the things we wanted to talk about today was acute pain. There are about 100 million people each year that are prescribed a medication to treat moderate to severe pain in the US. 80 million of those are for acute pain. And we felt there was some need to understand that a little better. Of those 80 million, for example, 40 million of those get an opioid as part of their pain management. So we conducted a survey called State of Pain, which went deeper into what's the experience that people are having with their acute pain. And we learned some interesting things through that. We did 1,000 patients last year, 2024, people that had experienced pain and gotten a medication for it, and 500 HCPs or healthcare professionals that prescribe those medications.
Right. And then what did you learn from that? So like what kind of challenges I get to present themselves when you look at acute pain?
Well, what we learned were a couple of things. Well, actually a lot of things. There are a lot of questions, and you can see the full survey on our Vertex website and the iPads around the room.
Yep.
But I think some things that stuck out to me was that acute pain, we think of it as maybe lasting just a couple of days. What people in the survey said was that they missed on average 19 days of work due to their acute pain episode. So it does have a significant impact on their life. And the other thing we learned is that most people who had this experience with acute pain, if they were to go back and do it again, which most of them don't want to do, is to have a non-opioid option. And this we heard from both physicians and patients.
Right. So then how do you spin that forward a little bit? So you've taken those kinds of lessons. How do you think about applying those?
Well, I think it comes down to dealing with the challenges that we see with that landscape. And there are several, and Dr. Motov talked about a few of them. But the first is that there just hasn't been a lot of innovation in the pain space in the last decades. Just no new medications, no new approaches, a lot of interest in that, but nothing really coming to the fore. The second bit is access. Because of the way the medical system is set up, new medications often have to take a back seat to the existing standard of care. And if that's an opioid, that means that people might have to take an opioid before they get to a non-opioid option, which kind of defeats the purpose. I think the other things that the other challenge is that there isn't enough communication. There isn't enough conversation between the physician and the patient, and we're hoping that through conversations like this, we can raise awareness of the importance for people to have a plan for their pain management, a plan even before they go in for their surgery. That's a little more difficult if you're just getting injured because you're not planning to get injured. But for surgeries, it's possible to plan ahead.
Well, I love these kinds of conversations because like when we convene a group upon these kinds of topics, you get the people who kind of care, who can even make a difference. And so from that vantage point, with this study, thinking about these kinds of challenges, what's a call to action for the folks who are here? How can they contribute to solving some of these problems?
Well, it's great to see so many people here, and it's great in all of the cities that we've been at to see the variety of stakeholders that are coming forward to learn more about pain. And what we would offer for you all to think about is you're here for a reason. You're here because you're interested in some aspect of pain management. Maybe you were affected personally, maybe you're an advocate, maybe you're a physician. Whatever that is, use it. Use it to spread conversations, to increase awareness about the need to treat pain better. And whether it's driving innovation, whether it's driving access, whether it's promoting conversations, even whether it's better ways to measure pain. I'm struck by one of the panelists from Washington, D.C., Stephanie Van, who spoke about maybe needing to rethink what our goals should be in pain management, because it's often a score. What's your pain score, 0 to 10? And what we hear so often is, that's not that meaningful to me. I can give you the number, but really what matters is what I can do or what I can't do. And someone might tolerate a little more pain if they're able to do something, if they're able to get up, walk around, not feel like they're, anesthetized, right? To feel normal. So I think the call to action is to learn, to share, and to advocate.
And why this moment?
Well, this moment's really important for a couple of reasons. One is that we're still in the middle of a health care crisis due to the opioids, but more generally due to the fact that we don't have enough options to treat pain, and it is so ubiquitous. So that's one reason. The other reason is that there is progress. There are new ways to treat pain coming forward. There are new methods, and we just need to be more intentional about and focused on bringing those new ideas to patients.
Being open to trying this a new way, everything, having those kinds of conversations, changing the way we measure it at this moment now when we might have new options.
You know, we had just heard about the ketamine example.
Yeah.
You know, something that's known to work, but we really don't have a protocol. We really don't even have a product that we can offer patients. So I think there are many examples of progress being made in our understanding of pain, but we need to translate that to the patients. And that's where conversations like this help us all figure out what is our role in doing that.
Before we get the hook here, I want to end on one final thing. Maybe take a step back. Like, we've had 4 conversations on both coasts around the country. What have you learned from that? What's your one big takeaway from this journey?
The big takeaway for me, and I've been working in pain as a scientist for 30 years, is I didn't understand it very well. And listening to patients and caregivers and advocates has really made me more curious to learn more about patients' experience. You know, I've been trained to think about pain as a physiological process, you know, something that we have to interfere with and inhibit. And certainly there's a role for that. Mm-hmm. But what I've come to appreciate is that there's a more holistic backdrop for pain. You know, mental health is important, physical activity is important, and just the medications by themselves aren't enough, but maybe just exercise isn't enough either. So we have to maybe combine all that we know to treat pain. So, you know, learning about that through these conversations has been really impactful.
It's interesting, and like so many of the conversations I have about the healthcare profession are about bringing it back to the patient, keeping it patient-centered. How does the patient feel? What can they do? How can they get their life back? It feels like those are the conversations you've been having around the country as well.
Indeed, and you know, one other thing I'd say is that our conversations, which we thank Axios for helping to arrange, have been in 4 major cities. Mm-hmm. We started in Washington, we went to Miami, San Diego, and now here in New York. And incredible variety of perspectives just in those cities on the different coasts, but we didn't go inside the country. We haven't talked to folks in smaller cities, in rural areas, and I'm just wondering what their experiences are that they can bring. And so curious and interested in continuing, you know, the conversations.
Well, I hope to see you again soon. Paul, thanks for being here. Huge thanks to Vertex for making this series of conversations possible. Stick around. I'm going to get my colleague Erica Pandy up here to continue it.
Thank you. Thank you, Dr. Paul.
Please welcome to the stage Axios senior reporter, Erica Pandy.
Everyone, our next conversation will be about policy, advocacy, and why everything we're talking about today is personal for our next speaker. Chris Assini is Director of Policy at Friends of Recovery, and before that he worked in the New York State Senate shaping legislation. Let's welcome him to the stage. So Chris, professionally, you're passionate about recovery processes, making them equal, making them accessible, innovating there. But you also have personal stakes here. Can you tell us a little bit about your own experience and 1 or 2 key things that showed you about where the current conventions, the current systems are falling short?
Yeah, absolutely. So my name's Chris. I'm a person in long-term recovery, and as you know, I'm the Director of Policy for Friends of Recovery in New York. So addiction was something that was around me my entire life. I had a family member who struggled with gambling, and you know, you would see the effects firsthand. You know, the car repossessed, the fights, etc. And you, despite the genetic disposition, you say to yourself, "That's never going to be you. You're never going to end up like that." And you know, I went away to college. I was introduced to prescription pain medicine. Ultimately, it led to OxyContin, and was within weeks, you know, that I was not just mentally hooked, but physically hooked. Fortunately, over the course of time, you know, an intervention from my friend, I went to a detox. I was able to attain what recovery was. I had no idea what recovery was at that time. I was able to start a position at a job that I absolutely loved. I was working with folks. It was minimum wage, working with folks with individuals with disabilities. You know, really kind of put in perspective just how privileged, lucky I was. And as I was there, I finished my degree, 9 years sobriety, ended up struggling again, ended up having a reoccurrence, primarily started with my mental health, quickly had a reoccurrence with substances, and I left, I quit. This job that I loved around coworkers I would have considered family, the shame, the stigma was too much. And I ultimately ended up taking a position at the state. And obviously I had not rectified any of those issues that I was struggling with. And I started to drink, something that I had never done before. I was working really extreme hours because I was working at the legislature at the time. And during session, you're working 24-hour days, which is accurate. There's a thing in the Constitution, in the state Constitution. I know it sounds crazy, true story. And I drank like I used. I was waking up at 4 o'clock in the morning to have a drink, and this went on for a number of months. I realized the situation I was in, went home. Ultimately, it was a beautiful spring May day, I'll never forget it, and I had found 2 bottles of wine. And when I was found by my family, I had aspirated, and I was in the hospital with liver failure, gastric bleed, and aspiration pneumonia. So I had to learn how to walk again. I had to learn how to talk again, looking like I was going to be cognitively, limited. So my first interactions were with, a social worker afterwards, where we had these interactions, and they were, testing me to see my disabilities. Anyway, I did it all again 8 months later. And which brings me to here. And some of the really systemic changes that I think we need to make are some of the things that I really noticed. First of all, we need to take just collectively a public health approach to things. For far too long, we've had stigmatizing, punitive policies that have kind of colored the framework when it comes to substance use disorder. When I say, a public health approach, I'm talking about the social determinants of health, economic factors, social factors, environmental factors, housing, things of that nature. Specifically as I said, I struggle with mental health, and 45% of folks are going to struggle with co-occurring disorders. An integrated care system, not just within the SUD field, because we're really siloed, between prevention, harm reduction, treatment, recovery, but, into the health system at large, a much more integrated system. And it's still, in 2025, wild to think that folks are going to be discouraged from treatment because of their co-occurring disorder. We can't treat both of them at the same time. And lastly, just general access to care, access to adequate insurance. And I singled out where I was working because I had unbelievable access to insurance. My insurance was fantastic. I had a job that could accommodate what I was going through. If anyone was going to find success, it was going to be someone like me. Most folks don't have these luxuries.
I want to ask you, zooming out a little bit, preliminary CDC data out this month gave us some good news that we haven't had in a long time. Things are still bad. This story is still so common, touches almost every family, if not every family.
Yeah.
But drug overdose deaths in the US last year fell to their lowest annual level since before the pandemic. I know different experts have different theories on what's happening here. As someone who works in this space every day, what's your thought? What is finally driving this decline?
I do want to say a couple things before I get into the decline, because we need to celebrate all of, any decrease in overdose deaths. We do absolutely need to celebrate. But it's been unequal. Folks, Black and Latino populations have seen overdose stress surge in recent years, tripling. 40 are, the overdose is still the leading cause of death for those under 45. But what I think has really made the difference in the last 4 years, especially, is there's been a really concerted effort to, educate the public. But we've really leaned into harm reduction strategies, naloxone distribution, fentanyl test strips, xylazine test strips. We do a whole bunch of work at Friends of Recovery New York, partnering with other community-based organizations that aren't necessarily, related to substance use, to do naloxone distribution. I think those are the things that have really made a difference. And culturally, these were naloxone harm reduction. This was a taboo topic, 5 years ago. Folks still really had struggled to wrap their head around it. And I think those are, it's been a whole myriad of reasons, but, I think those reasons are probably the top that come to mind.
And then looking ahead a little bit, if you could wave a wand and change one policy, either at the New York State level or federally or even at a city level, just if you could do one thing overnight to support people in recovery or people seeking recovery, what would that be? And I know I'm putting you on the spot here.
Yeah, there's so many great policies out there, and
You can give me two.
Okay. Well, I touched on one thing I do want to touch on. I had said the criminalization, punitive policies. We really make it difficult for folks who, are struggling with substance use who end up in the carceral setting or end up in carceral settings. We limit their job opportunity, their housing opportunities, access to insurance. So we've actually made progress in this, drop the box initiative to get rid of, background checks, things of that nature. But collectively, in the recovery community, the backbone of the work we do is peer services, certified recovery peer advocates. And, we're a series of community-based organizations. So the continued expansion of peer services into a multitude of different settings, employment, for example. There's this great initiative, Recovery Ready Workplaces, which puts folks in recovery back to work, creates a safe and supportive environment within that business, and is a really wonderful anti-stigma initiative on top of it. And considering just the totality of the cost associated with the overdose crisis, which I think there was data that came out earlier this week, and it was put at 2024 at $3.96 trillion, which is just unbelievable to digest. But peers also, we've made really great progress in courts, in jail settings, in hospitals. I would love to see certified recovery peer advocates expand into a multitude of settings, working with their local police, working with folks who are prescribing medicated supported recovery. There's just I just think it's a really necessary complementary aspect of treatment to our traditional clinical services.
And then what's the misconception that you still see out there that either policymakers or just general people in the public have about opioid addiction and recovery?
Well, I mean, stigma is still a real major issue. But I think the most important misconception, the most important thing to really internalize is that, recovery isn't linear. And I think that's a really hard concept for folks to kind of wrap your head around, because it can be so difficult. If you have a family member or a friend who's struggling with substance use, and and the reality is it takes time, and it's going to look different for everyone. I wish it was just a straight line, but in reality, that's probably not going to be the case. So that's the one misconception, and just in general, that folks do recover. I think we still have this preconceived, outdated notions that your recovery looks like you go to treat you reach your bottom, which is this old stigmatized trope. You end up in treatment, and then you're in a church basement, and it's much different than that. And there's a multitude of pathways out there where people are going to find recovery. Most people will not find recovery even going into a treatment setting. So. Yeah.
We have about 90 seconds left. I have one final question for you. You work for Friends of Recovery.
Yes.
For folks in the audience, what does it mean to be a friend of recovery?
That's a really good question. Someone who supports and puts actions behind words, who supports folks in recovery, friends or allies to those in recovery. Understand. I'll give you an example because I'm struggling to find the words. But I was at they were opening up a opioid treatment program over by my house, and
that's Albany, right?
That's Albany, and it was adjacent to Albany. It was actually in Albany County. We went to this big public hearing, and you had folks in there who would say all the right things, but ultimately that not in my backyard attitude won out. So actually putting practice, putting their money where their mouth is, if you will, I think is really, really important. And I think, once again, I think we know the right things. We know it's a disease, but we still, in practice, don't actually, adopt that mindset.
Chris, thank you so much for your time, and thank you for sharing your own story. I think that was great for us all to hear. Thank you so much.
Yep.
Program, Maya Goldman is taking the stage one more time.
you so much to Erica and Chris. Round of applause again. To close out our event, I'm joined by a pain specialist and professor at Montefiore Einstein up in the Bronx. She's a national voice in whole person pain care, bringing deep expertise in acute and chronic pain, addiction, and cancer care. Please welcome Dr. Karina Gritsenko. Hi. Thank you so much for being here. It's great to see you on our stage today.
Thank you for having me.
So I understand you have a little bit of a personal story of how you got into pain management. Tell us what sparked your interest.
So I think that I always knew I was going to be a doctor, even if I did theater and music before all of that. I lost a lot of my family to cancer in different situations, and I became very good at working with older people and also caring about a graceful death. And so I became very passionate about analgesia in the long run.
Yeah. What was your path to getting there from starting out?
I was lucky enough to be accepted into an early acceptance program for medical school, and I really liked the journey of, I guess, watching people be in pain and helping them feel better.
Yeah.
You know, in both the acute setting and the chronic setting and all of that.
Yeah. So as you mentioned, you work in both chronic and acute pain management, and I think a lot of times people think of those things as very different and very separate.
Yeah.
What is different and similar about those areas?
So it's kind of like cooking. They're all the same ingredients. It's more how you use them. You can use salt in chocolate chip cookies. You can use that in fish. And they're very, very different recipes, obviously. But I think there's a lot of nuance to that in terms of ERAS protocols, parasurgical home, and being able to incorporate all these different ingredients into one pot. One of the things I talk about with residents, with fellows, with all trainees is that pain is like a bomb. And so my job is to be the electrician to detonate it in the right way or not detonate it. And so you have to understand, is it neuropathic pain? Is it nociceptive pain? Is this a myofascial pain? Is this somebody who is suffering with an acute problem that is solvable and likely going to resolve? Or is this something longer term and brewing? And so really differentiating between those pathways is quite important in terms of how you nuance your recipe.
Mm-hmm. Is it becoming more common to bridge that gap between acute and chronic pain?
I think I was kind of a weirdo when I started out, frankly, because I really do work with both of those roles. Sometimes I wear the hat of the acute pain doctor, and I really care about being a sous chef of fish. And sometimes I care about being the dessert pastry chef. And it's similar in that you have to pay attention to the patient, and you really have to listen to your patients and what their concerns are. But oftentimes we have a limited pool of ingredients to use, and we just have to be thoughtful about how we use all the different medications and interventions that exist to do a good job.
Does chronic pain always start as acute pain? Is it possible to prevent chronic pain if we prevent acute pain?
Now you're sitting on my soapbox. This is something I'm really passionate about, actually. I think that historically, acute pain people talk about acute pain, and chronic pain people talk about chronic pain. And there's definitely been some nuance about trying to be a good Sherlock Holmes and figuring out who are the patients that are going to go from acute pain to chronic pain. If we look at classic definitions, we expect acute pain to resolve within 30 days because that's really what we're paying attention to, right, in that first 30-month period. If we're talking about chronic pain, the definitions of chronic pain that are known or actually defined are 3 months or more, and that's the definition of chronic pain. And then there's something in the middle that's this gray area that they call persistent pain, or maybe something in between. And there's been literature that's indicated that, hey, maybe if people have really, really bad acute pain, even post-op day 0 of any kind of surgical intervention, maybe that's a predictor for their opioid use 1 year later. And there have been even abstracts from the Euroanesthesia conferences as of 2015 that I can recall off the top of my head talking about this kind of data. So I think we have some clues to that. I can't tell you exactly how that happens, but of course these things develop and nuance, and it's a really, really important area to continue to explore.
Yeah. So we heard earlier about pain management beyond opioids in the acute pain setting. What does that look like in the chronic pain setting right now?
use all the ingredients and use them really, really well, and also develop long-term relationships. One of my old attendings said to me, make sure this is a patient that you want to marry, because it's a long-term relationship. Pain management is tricky. I have the luxury of being an interventionalist, of being able to do procedures, of being able to have long-term relationships with patient, even though I'm not their primary care doctor. So I get to do sophisticated subspecialty stuff and manage the conservative management, the medications, the interventions, and in some cases surgery for patients too.
Yeah. So are opioids still the first line of defense in chronic pain, or?
Oh God, you're giving me a heart attack. No, definitely not, unfortunately. Obviously, there are certain patients where opioids are appropriate, and they should be, and definitely cancer is one of those things that comes first in my mind. But in general, I think the culture has shifted away from opiates as a first-line treatment for chronic pain. In fact, even if we look at the there were some guidelines that first came out in 2016 with many of the pain societies and the anesthesia societies specifically saying that really we haven't proven that opiates have been useful to be used 1 year out from a procedure or whatnot. Are people titrated according to needs? Absolutely. Do people have chronic needs? Yes. Do people develop addictions? Absolutely. Do people develop tolerance? Absolutely. All of these things are certainly part of the milieu and package, and it is certainly an ingredient in my kitchen, but it is not the mainstay if I can avoid it.
Tell us about some of those other ingredients.
So
Spices in the spice cabinet.
Well, I can't tell you all my secrets, right? What kind of a Michelin restaurant would I be?
Yeah.
You know, there's a lot of different things, and just like the WHO ladder, which has been in existence for so long, we start with nothing, or conservative management, exercise, etc., diet, healthy lifestyle, don't smoke, and we escalate from mild agents to moderate agents to significant agents. And there are steps that are in place for a reason. Initially, some of this data came out with cancer pain, and the idea was to actually improve morbidity and mortality, and it did that. And the same thing correlates from the cancer pain setting to the chronic pain setting.
So you're saying improving pain and managing pain can actually help you live longer.
And not just that, doing it in an organized fashion. So actually having a plan as how you escalate any medication that you use is very important. I have patients who come to me and try, I'm going to give a random example, gabapentin 300 milligram, 1 tablet. They say, well, gabapentin doesn't work for me. Well, you tried it one time. Maybe it's because you didn't use the medication correctly. So patient education is just as important as prescribing any medication that you use, and really working with your patients to make sure they understand how they're using it, why they're using it, what are their side effect profiles on anything. And that was just a random example of any medication. It could have been Motrin or Tylenol for that matter.
Yeah. Switching gears a little bit, you mentioned death with dignity is a big passion of yours, and you work on palliative care and hospice, which is all about pain management and comfort. What does that look like right now, and how is palliative care pain management changing?
So I'll tell you, I have certification in palliative care, and I'm involved in some way, although it's not the majority of my practice, although I do incorporate all of that training into every acute pain consult that I see and every chronic pain patient that I see, because it's not just that palliative care is not hospice. Hospice is when you're dying with dignity. Palliative care is when you're living with dignity. And so I think
good way to separate that.
We'll segue it that way. And I think that incorporates every patient I see. When I see a sickle cell patient in acute crisis in the hospital, they need to live with dignity in the hospital. And I see quite a lot of that. When I have a patient with chronic diabetic peripheral neuropathy, they need to live with that pain. And they need to live with dignity. They need to get through their ADLs. They need to have a functional life that is meaningful to them. You know, whether it's being at their grandkids' wedding or, you know, just driving their kids to school. So in all of these different circumstances, it's important.
Yeah, absolutely. We talked before we got on stage about equity in pain management. Broadly, what does equitable pain management look like to you?
I think it's listening to your patients. You know, it doesn't matter what insurance you have. Well, it kind of does. I'm sorry. I'm not supposed to say that on live TV, right? But it does. But it shouldn't matter what insurance you have. It shouldn't matter where you're from. It shouldn't matter what language you speak. It shouldn't matter what zip code you live in. You should be able to have access to the care that you need, right? And I think that for me, though, the question I always ask, any resident or fellow will tell you, I'll ask them, what does the patient want? Why are they here? You know, I'm afraid of pills. No, I'm afraid of needles. No, I just want to lose 5 pounds, or whatever the case may be. You just have to really listen to their needs, and that's really what that's the core of taking care of any patient. Because you know, every doctor has this moment of, you know, any patient that comes to see them, they're coming because a patient needs something. They're unhappy with something. Pain is like the moment of why you go to a doctor. Something is wrong with your life, and I have the luxury of doing that every single day in all aspects.
Yeah. So how do you balance that and wanting to help patients with what they want while also, you know, adhering to clinical best practices?
You follow the clinical best practice, you offer patients what's on your menu, and they get to choose out of the options of what you think are viable options with risk-benefit assessment, and then you have a conversation, just like I do with my children every day when I try to pick out their breakfast.
Yeah. If you could wave your magic wand, Karina's magic wand, how would we make pain management more equitable for people?
That's a really hard question. It would be nice if cost was not a barrier, and it is. I have patients, I work in an underserved community that I love, and sometimes the most frustrating moment is when my patients tell me they can't go to physical therapy because they can't afford the bus fare. And that has nothing to do with the medicine, but has to do with a completely other world that we could spend a whole hour talking about here at least, or more. So I think that just being there and just contributing every day is what does it for me. Mm-hmm. And world peace would be nice.
Yeah, yeah, that would be good. That's a good magic wand to wave. We like to end sometimes here at Axios with one fun thing, and this is sort of a heavy topic, so I think it's important to end it out on that too. What is the best part of your job?
Oh, this is easy. You gave me a gimme. So I am a woman in medicine. I'm sorry to all the gentlemen in the room. I'm a full professor. I'm a mom of 4 kids. I have 4 boys at home and a husband and parents and all of that. And I love the fact that I talk about my family at work because it normalizes it. And being a woman in medicine, it's really important for that to be okay. And so I get to mentor young minds, men and women, and I get to show that it's okay to have a family and okay to talk about the donuts for your 8-year-old's birthday party and also talk about ERAS protocols.
Yeah. It's working moms.
Easy.
Amazing.
Easy.
Thank you so much, Dr. Krasenko, for joining us.
Pleasure.
Thank you.
Thanks.
And that wraps up our program. Thank you all for being here. We'll see you next time.